So OPQ-RST, I'm going to skim through questioning because they're very similar. I'm just going to try to skim the parts that I think are different. So when did symptoms begin? Sudden or gradual? What were you doing when it started? How have symptoms changed since they presented? Anything make your symptoms worse? Activity, movement, does shortness of breath increase or decrease with exertion, with movement? Do you find positional differences with movement? That's important. So shortness of breath increases with body position. That could be useful from like laying down. CHF patients do not like to lay down. All people that are short of breath like to sit up because they hang their lungs, but CHF patients do not, right? Like if I lay down a COPD patient, they're like, do you mind sitting me up? CHF patients, they're like, right? Like they're like, no, I can't lay down, right? Like they do that, right? In comparison, like COPD, well, like you move them a bit, and they're like, you move them from their chair, and then they go to this angle, they'll be like, do you mind sitting me up? And CHF is much more panicked about it. So that's a very good, thoughtful question to say, why are you so freaked out laying down when you're short of breath? Because some of these patients with COPD that also have congestive heart failure can be masked presentations. We'll talk about those a little bit more. So body position is important. But you notice all the same questions, right? From the last one, cardiac will be all the same, okay? Just different order. If they have pain, then we can have them describe pain. If they don't have pain, then we can have them say, when was the last time you shortness of breath? Did you have shortness of breath like this? What is this shortness of breath that you're experiencing? Qualify it somehow. If they've had it before, they'll describe, oh, this is my COPD, this is when I get pneumonia, this is when I have an asthma attack, this is when I have a really bad asthma attack. They can also rate it as far as severity. Obviously, referred doesn't apply if they don't have pain. But as far as severity, shortness of breath rating scale 1 to 10 is very useful rating. You're a 10 out of 10. What happened the last time you were 10 out of 10? You were intubated. What's going to happen today? You're going to be intubated. So, like, you can paint the past will tell us the future. And then restate back the things that you've learned to your patient as far as the things. But pay particular attention here, things that you might not be doing, is enough questions around onset and how things have changed, and then things making things better or worse. You're probably doing the rest. And maybe you're doing it all. Allergies, medications, same thing. Determine why patients on each medication, whether they're compliant, and if there's been any changes to medications, new or discontinued. Past medical history, we'll start off respiratory. So do you have any diagnosed lung problems? No. Okay. You've never been told you have asthma, COPD? You ever had bronchitis or pneumonia? Kind of paint a couple of options. Symptoms. Have you ever been short of breath like this before?
No.
Okay. Do you have a cough?
Yes.
Okay. Are you coughing anything up? So sputum production?
Yes.
Okay. Well, so what are you coughing up?
Green sludge.
Oh, well, that's very helpful. Nice. Green sludge was very helpful. We're into at least one diagnosis, right? So we've got some sort of lower respiratory tract infection. If you're coughing up something green, brown, sometimes it can be white. That's a little bit more difficult. Different things grow different colors. So sometimes white in chronic bronchitis people will be an increased production. So how has your sputum increased? Normally you cough. When do you cough? How often do you cough? If you normally cough. And what is the change today that you're saying, okay, no, I've been coughing more? Can you describe how much more have you been coughing? Have you had a lot more sputum? Any changes in color or consistency? Any presence of blood in it? And I've already asked if they have any history of pneumonia or bronchitis, which risk factors, if you have a history of it, you're more likely predisposed to have it again. Orthopnea, have you been short of breath while laying down? Okay. And realize that every patient that's legitimately short of breath is going to want to sit up. So if you walk in and somebody's truly got 10 out of 10 shortness of breath and they're laying down, they're in respiratory failure, okay, because they can't sit up, okay? So if laying down, right, not having adequate tidal volume and thus inadequate minute volume usually. So usually respiratory rate is present until close to death. It's usually tidal volume that goes first. So the next thing, as far as orthopnea, is the question, really good questions around people that have got increasingly short of breath over the last week. So have you been short of breath? When have you been waking up short of breath at night? Okay, what have you done to resolve that? Well, I sleep. So almost every congestive heart failure patient that you'll manage that's not acute onset in the nature of like an MI or blow a valve or something of that nature will have this history. Yeah, I've been swelling more in my ankles, been waking up short of breath at night. Normally I sleep on a couple pillows. I went to 4 pillows. Now I'm sitting straight up in a lazy boy chair. Or else I wake up short of breath. Right? You lay them down, they get short of breath. It's a very, like, I can see you have an increased central venous pressure that you're managing by your body position. Right? Precipitating factors, are you a smoker? Are you on home O2? And then, of course, if they're on home O2, how many liters and what's your normal SpO2? Because we'll be titrating to that. There'll be a few other precipitating factors there that might be, if we're thinking like pulmonary embolism, if they've been sitting or stagnated for a long period. But that might fall under more cardiac pain differentiates. But you could ask if they had pain in this mix. If they have pain in the mix with shortness of breath, generally we're doing cardiac assessment and respiratory assessment interwoven. The questions are the exact same order and structure purposely. I'm just going to add a few questions in together to kind of cover off both bases. If they have, so then if we're cardiovascular, here's the questions for the cardiovascular system. That'll be the exact same as on the targeted cardiovascular assessment. So do you have any history, diagnosed conditions of heart problems?
No.
No? Okay, never been told you have slow heart or fast heartbeat?
Doctor.
Okay.
A slow heart.
Oh, you have a slow heart? Okay. Do you have any history of anything like angina? Never had a heart attack? Okay. So we kind of covered off arrhythmias. Symptoms. Have you ever had any episodes where you feel like your heart's racing?
No.
Never had episodes where you have chest pressure or tightness or pain? Okay. Do you find that you've been getting short of breath when you're walking?
No.
Okay. So it depends on what the presentation. If he had pneumonia, he still might have exertional shortness of breath, but he shouldn't develop as a young, healthy man ischemic chest pain like that. Right? Even in geriatric patients, walk around a bit, probably not going to get ischemic chest pain, even though they have a pneumonia. They'll be able to oxygenate adequately. Their respiratory rate and volume and experience of symptom of dyspnea will increase, but they probably won't get to the point where they'll get ischemic heart pain. So we did palpations. We asked about edema, which I've already asked about, if present, and any kind of history of generalized weakness or presyncope or syncope. Okay. Having been feeling dizzy when you stand up, feeling like you're going to pass out, which is abnormal to you. Okay. Lots of times when people just generally are unwell, they'll experience presyncope. They get lightheaded when they get off the couch too quickly. Precipitating factors, cardiac risk factors, recent surgeries, or stagnant positions. So if they have chest pain, then we need to go through all cardiac risk factors. Last time you experienced symptoms like this, if you had symptoms like this, what was it? Okay. How was it treated? Any ongoing medical tests, doctor visits, last oral intake. If we're thinking that we might intubate this patient, that becomes an important question for us to know. And how have you been feeling the last month, last week, last day? Cool. From history points, so pretty well the same thing. Again, just different questions. But once again, the exact same order where you go diagnose conditions, symptoms, and predisposing factors in every area, which will help you kind of guide you. And that you'll be able to frame your questioning around that so you don't miss things. General impression, expect the patient to be tripoding if they're significantly short of breath. Why do people tripod? Because they hang their lungs. Lungs are like slinkies. If you lay them down, they don't stretch out as much, but if you hang them, they hang out further. Okay? So you get actually increased tidal volume by hanging your lungs, by sitting up. That's why everybody, when you're short of breath, you want to, right, you splint your lungs out. You may lay collapsed with your arms above your head, but after your relay or your marathon, triathlon, whatever. So position, tripod, supine. Be concerned with supine. If you're supine and short of breath, you're either not short of breath or you're in respiratory failure.
I learned in nursing home and they just didn't look that up.
Well, significantly so. So notice things, so inspection head, so we're going to look for things like nasal flaring, particularly in the pediatrics. We'll look for pursed lip breathing, cyanosis, and around the mouth. So we're just going to watch and see. Pursed lip breathing, respiratory pattern is incredibly important, and we skimmed over this in PCP school as well, at least I did. I had a 5-month course, so I got like 3 months, 3 months of through Mosby's, pat on the bum, out to the trucks. Yeah, you'll be fine, and then off to the trucks. So it's how that looked like was my experience. So I got it was great for 5 months. I learned a tremendous amount. Came in knowing nothing about anything about human stuff, and then left. So I got something out of it, but maybe not to the point that I should have been treating your mom, right? I really love my mom. I'd like somebody to be confident in treating her. I didn't kill too many people. Okay. So pursed lip breathing, with breathing patterns, it's really important that we note, watch for inspiration and expiration. What's normal inspiration to expiration pattern?
1 to 3.
Okay, 1 to 3, maybe 1 to 4, maybe. But we normally inspire quickly, right, and take a little longer to exhale. But you notice in a normal respiratory cycle, we go inhale, exhale, pause, inhale, exhale, pause. Okay? What happens with everybody that's got an obstructive lung disease is they go inhale, quick, exhale, don't stop with a pause, inhale again. Right? That patient's air trapping. So you can tell somebody's an obstructive lung disease patient by watching them breathe across the room going. Because they never have a respiratory pause. Okay? So both auscultation, we've been notorious for doing, okay, breathe in, breathe in, breathe in, breathe in. Okay? But we need to breathe in and out. We need to listen to the whole respiratory cycle, because you'll hear some adventitious sounds. So you're much more likely to hear wheezes when? During expiration. When are you likely to hear crackles? During inspiration. So let's listen to both, inspiration and expiration. Even for a couple of breaths per site would be good. Conjunctival pallor, so once again, anemia can cause shortness of breath. So we're in the head, we're going to look in the eyes to say, okay, eyes clear. Can you open your mouth, stick your tongue? No cyanosis, mucous membranes are moist, no pursed lip breathing. Or there is pursed lip breathing. And no respiratory cycle as per inspiratory to expiratory ratio, because that's very informative. You can also tell somebody's getting better by an inspiratory to expiratory ratio. You start noticing they get a pause back, you're like, hey, I'm fantastic. I wouldn't even have to listen to lung sounds to see that across the room they've improved. You knew they were improving. You might not have been able to articulate why you were saying they were improving. They don't look as short of breath, but it's much more objective to say, actually, I'm seeing a respiratory pause now. So, hepatojugular reflex, if we're thinking once again for, if we're turning your head to the side, if we see any jugular venous distension, so I wouldn't do hepatojugular reflex on everyone. If I saw jugular venous distension, so I see his jugular veins here, once again, the same spot as he's sitting here. He's not quite, he's a little higher than 45, so let's put him back there. Obviously, I have to be particularly careful with this. So look, I don't see any. So I don't see any jugular veins. Like I can hardly see jugular veins at all. I don't think he's in heart failure. What happens to somebody that's has obstructive lung disease?
Thoracic pressure.
Increased thoracic pressure. So you're likely to see increased JVP. But how will they react when you apply jugular venous pressure?
You just compress their lungs, not very.
Well, no, you're actually going to increase. You're going to see a bolus through. You'll actually see it elevate, but they'll handle it. It'll go back down to where it was. Whereas somebody that's in heart failure won't. Does that make sense?
Mm-hmm. Right.
So that's why hepatojugular reflex is really useful, is if you see it, we can go, bloop, goes up, stays up. That is usually heart failure, some sort of backup.
So,
It might be a test to see if CPAP is working.
If somebody's no CPAP, no,
Increasing
you.
their intrathoracic
So you are
pressure.
in, but I won't be able to measure. I'll be able to see if their CPAP's working. So CPAP doesn't help clear fluid, and it doesn't increase cardiac outputs. The heart's still, they're still probably going to have to go on some drugs, right? So just because they're going to go on something to decrease fluid levels in the body in general, they're going to have them dilate and pee.
This fluid's still gonna
But
be
all
there.
that we're doing with CPAP is blowing the fluid out of the lungs back into the vascular system so they can oxygenate and ventilate appropriately. So it doesn't actually fix the heart failure. It just fixes one of the symptoms associated with it. Does that make sense? We don't have good treatment for heart failure, depending on the cause. Right? If your muscle has just got big and flappy and doesn't pump well, we can do things to increase contraction and slow down rate with some drugs, increase strength of contraction, and then we make you try to manage your symptoms by making you dilated and pee. That's heart failure management, right? We don't have a lot. We can't. You mean heart transplant? Need a new heart. Okay. Valve transplant, maybe. Fix mechanical valves. Huh? Fix the MI that caused the heart attack. Fix the arrhythmia if it was arrhythmia induced. So you could have somebody in VTAC that will still have backed up, right? So reasons why you have cardiac heart failure, it's the same reasons you have a low blood pressure, minus the vasculature system. It's the muscle, the valves, or the conduction system. Any of those things screw up, and you don't have good ejection fraction out of the heart. Okay? So any of those things could potentially, so that's why the extreme bradycardia could cause pulmonary edema. Extreme tachycardia could cause pulmonary edema. You blow a valve, you go get your teeth cleaned, and your dentist doesn't put you on antibiotics, and you have risk factors for that, then all of a sudden you get endocarditis, and you have some stuff peeling off the side of your heart, flapping in the blood flow. It's a really bad day. You can die, become septic because you get your teeth cleaned.
Nice.
So bad day. So there's lots of things that can cause heart failure that's not just muscle related. Okay? But around those things, electrical conduction system, valves, or muscle pretty much makes up the functioning heart. So hepatic jugular reflex. Trachea midline, so we can look and see, is the trachea. Now, his trachea, you can see his thyroid cartilage or Adam's apple very clearly. But in a pendulum, like if I'm pulling over on, if one lung, if the lung space over on this side is inflating and pushing over this lung, where's it going to move? Think of a pendulum on a clock. Where does it move the most? The bottom, right, compared to the top, right? If I see up here, I might not see any tracheal shift here. But if I palpate down at a sternal notch, I might notice that it's over. Remember, this is a near-death, if not in-death, finding. So the fact that we even mention tracheal shift is probably not all that useful, particularly if you're only visualizing it. So if you palpate it, you might actually feel that I can palpate his trachea right down at his sternal notch, whereas at the top, if I see, oh, trachea's midline, his Adam's apple is probably never going to move, even if his lungs are way over here, right? Because you see much more that his lung gets pulled over here, Adam's apple's still in the same spot, right?
Now, with one lung, would that be fairly normal to see that?
No, one lung will actually shift to the mediastinum. It'll actually come over.
Okay. So you wouldn't see tracheal
No,
deviation?
you wouldn't. But tracheal deviation is not a great thing. Whereas jugular venous distension, you will always see gross jugular venous distension with a tension pneumothorax. Now, throw on top of that, if they have blood, if they're not bleeding it out on the floor or into their belly, they will have. Becomes a little bit more complicated if they're bleeding excessively, right? So the blood, it would be backed up at the heart because the lungs are sitting on the heart essentially, right? Doesn't allow the heart to fill adequately, so you don't get adequate stroke volume out. But because it doesn't get there, it doesn't back up. Right? So given that, okay. So trachea midline, so tracheal shift. And jugular venous distension, once again, becomes very important, right, to actually look at central venous pressure and try to predict. But I see no jugular venous distension. It's so helpful with heart failure compared to COPD. Okay, very helpful. Chest inspection, scars, rashes, lesions. AP diameter. Do they have a barrel chest? So he doesn't. He's only 1 deep. What he is, 2 wide. So he's a normal AP diameter. Respirations, so inspector IE ratio. So you can get up to 1 to 2, 1 to 3, 1 to 4. What we don't want, so you think about running, right? Right, I go sprint across the yard, right? I'm compensating for the metabolic demands of my body at that moment if I do wind sprints, right? So I increase respiratory, but I will always have a pause. I'll fully exhale, pause, then breathe in. The pause will shorten, right? But it won't disappear completely. So look at the chest. Look for accessory muscle use, which is subclavicular, intercostal. You'll generally see accessory muscle use in somebody that's significantly short. I use accessory muscles when I go for a run, right? If I'm winning, right? Okay. You'll see more around the clavicles that you'll see lots of accessory muscle use, but pretty normal finding in anyone breathing. So they're using extra muscles. An objective finding says, yes, you're obviously short of breath. Any bulges, retractions, anything like that. Remembering that sometimes like flail chest and trauma isn't as screamingly obvious as you might think. So chest wall shape and symmetry. So we can have a look and see, does chest rise and fall equally? We can put our hands on and feel, take a nice deep breath for me. Feel that things move together. Okay. If I have you sit up, I can see chest excursion by palpation. So remember, so I can actually feel, as he exhales, his chest wall actually collapses some, okay, around the scapula. So if I get him to put my exhale all the way out, okay, put my hands on, take a deep breath. See how my fingers come apart?
No.
So you're going to have to come over. Okay, exhale all the way out. So I can measure chest excursion, okay, as I feel his chest open and close. Okay. So his chest wall is continually moving, right? In and out. So I can measure excursion if I wanted to, if I was hesitant. You can also see things improve that way. Have a seat back. So I would probably just on the front take a deep breath for me, shape, symmetry, adequate chest rise and fall. Palpation, we've measured symmetry. You could do that on the chest as well. If you want to get a little bit more measurable, you can go to the back and hold it back and have them take a breath and see how much are they actually moving. Somebody that's air trapping, you'll only get like a couple of centimeters, like 1 or 2, whereas he got 5 centimeters as he took a breath in. Right? So you get actual objective measurement rather than just, yeah, he's breathing shallow. I can say, well, they're only getting chest excursion of 2 centimeters. Percuss the lungs. Same thing. We did. Just one thing on AP diameter is 2 to 1. Is also when your chest comes out, you normally your diameter here as your rib cage comes together. This is usually about 90 degrees. As I become barrel chested, it will flatten. Okay, so it's another indication of barrel chest. Palpation in between intercostal spaces, nice and resonant. Eventually, you have a heart. But if I percuss 6 points, it'd be better if I was comparing side to side. Why do I percuss the lungs? Okay. So I could hear that there was air in the lungs with my stethoscope. Why would I care?
Consolidation.
So I will hear consolidation with my stethoscope. Percussion allows me to hear things where air is not moving through it. So if I have a pleural effusion, a tension pneumothorax, is air going in and out of your tension pneumothorax or your pleural effusion? It's not, right? This is outside the airway space.
Hyperresonance?
So we can get hyperresonance extra hollow sounding in a tension pneumothorax, or in a fusion we can get a dull side, right? So we're percussing because where air is not passing through.
In a pneumonia, you wouldn't hear dull sounds on percussion?
I don't think that you would.
In the consolidated area in the lung?
No, I don't think you'll get enough. I think it'll still sound hollow enough. We'll have to Google it. I love that I'm saying I don't think.
Okay.
I've not experienced that. I'll say that for sure, and I've never read that anywhere.
Okay.
I'm not saying it's impossible, but I don't know. That's what I know. I haven't read it yet.
All right.
Hemopneumo, would you?
So if we had blood, then we could get dullness. Yeah.
I've heard medics say you can kind of differentiate CHF and pneumonia through listen for the listen for the crackles or whatever, and then if you give them a cough, that you can get that to move.
Absolutely. So where you bring us on to the next part. So so we did inspection, palpation, percussion, and now we're on to auscultation. I'll just show you a diaphragmatic excursion really quickly. I'm not saying you're going to do this on every patient, but good for you to know. The same thing, we knew his diaphragm, where you breathing in or in? Resting.
Resting.
So I want you to exhale, and I'm going to percuss down and find your diaphragm. Okay, so it gets flat there. Inhale. Notice how it got hollow again? So dull again. So there's his lung excursion. So diaphragmatic, that's how much his diaphragm's moving. Okay? So that is diaphragmatic excursion. Optional. I'm not saying you're doing that, I just want you to know what it is. So I'm not suggesting that I do diaphragmatic excursion or measure chest excursion on the back on every patient. But I will come in and put hands on. But I just wanted to mention. So auscultate, remember where lobes are in the lungs. This is a common misperception of paramedics, is we don't know where lungs are actually. So if you go to page 7 of this assessment, it's got a great view. Often we listen 4 quadrants. We listen here, here, and usually people listen too low down here rather than armpits. So they go here, 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 and here, and say all lung files clear. So we have listened. Remember, lobes act like separate lungs, right? They're, in fact, when you open them up, they look like separate little lungs attached to tubes. Okay? So it's like you got 5 little lungs. Okay? Subdivided. Right side has 3, left side has 2. Right? But you can have a pneumonia in that right middle lobe, which you may never listen to. Okay? So we see here on the right middle lobe, so that's why we need to listen to 6 points, because you're missing a lung. It's not actually a lung, it's a lobe, but it functions the same. Okay, like it's separate, it's going to have separate. So we're going to auscultate here, 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 and here, and here. Okay, so listen to 6 points. Remember that we need to listen to inspiration and expiration. And we may hear different sounds. Most common are either wheezes or crackles. Okay? There's also a change in lung sounds. I don't know if you probably know this, but I don't know if you've documented between more bronchial lungs and get more vesicular sounds. I don't have a lot of time to get into it, but you'll notice on harshness and also what you hear based on inspiration and expiration, which sounds longer and which sounds shorter. Let's start listening and comparing even fields as you move down the lungs of how inspiration and expiration sounds based on each area. Okay? So you get more bronchial lungs, which are harsher and longer on inspiration, and vesicular lung sounds are longer on expiration. But you're just going to have to start, you probably know this to be true, but you just need to be more thoughtful about it when you're listening. That there's different sounds as you move down and get more to more just tertiary lung fields. There's alveoli when I listen here, but I also have these big tubes that come down, so I get more bronchial sound over the top. Whereas down here, I have less bronchials, right? More predominant alveolar sounds. So you can get changes in lung sounds that indicate pathology as well, as far as bronchial vesicular, or vesicular lung sounds. Tactile bronchophony, So when you're listening, and if you hear crackles, or if they have a productive cough, you are wanting to find out whether somebody has consolidation. So you can put your stethoscope in. You can have them repeat a statement. 99 is a common one. And it should sound muffled. So if they sound 99, it should sound like 99, 99. And if it becomes clear, you have an area of consolidation because fluid transmits a sound better than air. Okay? So you'll hear it clearer because there's junk in that area, so it transmits the sound better. So if he says 99, can you say 99 for him?
99. 99. 99. 99. 99. 99.
So it's muffled everywhere. So it doesn't have any area of consolidation. But it might be a good help to area to find out where I have consolidation. And if I hear crackles in that area, you can have them say 99 again over that area and compare. The other thing you can have them do is cough. And if it's a mucousy type secretion, then it will get kind of blown up against the walls, right? You'll be able to hear. You'll no longer have a difference in bronchophony. You'll hear no crackles until it kind of drips back down. I know, it's just like, and then it's going to get crackly again, right? They don't get it, and then sometimes they cough, and they actually cough some of it, get some of it out, okay? But there'll still be some left over typically. Okay? So for consolidation, we listen for inspiration and expiration, 6 points minimum. With a respiratory patient, I'd like you to list 6 front, 6 back would be far better, based on how stable the patient is. The more unstable, we'll leave them be. The more stable they are, listen to front and back. Okay? 6 points front and back. For back, sorry, sit right up. I'd like you to come here, here, and here. Okay?
If you had to choose between front and back, would you choose?
Ooh, I think I'd do front because you're going to hear the middle, right middle lobe, and you're not going to hear it on the back at all. Okay, sit on back. And that's another big misconception. If you look at the back pictures, notice that you have, like, comparatively speaking, back we have lower lobes and the upper lobes, and notice that most of what you're listening to is the lower lobes when you're listening to the back. Okay? So whereas the right, the side, and then lateral view, you're seeing a lateral view there. In the color, it shows much better differences there. But there's some helpful pictures that I was like, in my P1 brain, I was like, what are you talking about? I thought I was listening to the wrong spot. It's fine. We grow together. So listen, tactile fremitus is the same thing as bronchophony. You're just going to get increased vibrations. So if I have a patient with the bony parts of your hand, you can use the sides of your hand, or the bony, I just use here, and just have them say 99.
99. 99. 99.
Okay, you can see where this might be more difficult in female patients. Right? So this is 99 is probably easier, right?
That's what tactile what?
Tactile fremitus is when you feel increased vibration over an area of consolidation, where you have mucus and gunk.
Is it any more diagnostic than having a listen?
No,
Okay.
it's just another associated finding. They're both the same mechanism. Abdomen, we're going to inspect for scars, rashes, lesions, rounded or protuberant or scaphoid belly, any distension if we think of any kind of ascites or anything like that. We'll do light palpation and deep palpation. So we'll just feel just inspection and palpation. Don't need to percuss. If you think that there is need to percuss as you're going through because you think maybe you have pain, maybe you have some abdominal findings, if they look distended, then by all means percuss. But once again, you just go inspection, palpation, percussion, auscultation, what's pertinent to this patient. If they're complaining of shortness of breath with no abdominal pain, you don't need to listen to bowel sounds. Does that make sense? Yeah. So I can just do light, any pain. I'd expose, once again, any pain, right? Do light. I might not even do all that. I'll push a little bit deep, but I don't know that I have to. Light and deep. Let's just keep it straight ahead. So light and deep, again, as per the sheet. But obviously, if this were a respiratory call, I wouldn't do as much. So hepatomegaly and splenomegaly are useful with the deep palpation if you're thinking of congestive heart failure. They're going to be present in large liver or spleen because they're going to be engorged with blood because they're backed up with their heart. so you get backup in the portal circulation. In pediatrics, that's one of the first findings that's easy to find. Incontinence, extremities, any scars, lactions, regions, and skin. Motor sensory, can you push down? Can you feel this fine?
Yep.
Okay. Look at color, sensation, look for any cyanosis. We can look for clubbing of nail beds. Easy way to tell for clubbing of nail beds is to stick fingernails together. Okay, so can you put your fingernails together like this? Okay, and can you see a window through? Okay, so if I can see a window through the little diamond, then I don't have club fingers. Okay.
Say that again.
Just put your fingernails together like so, and you should be able to see a diamond through.
Gotcha.
If you don't have a diamond in the middle, then you got club fingers. Yes.
Might there be something diagnostic about asking for incontinence? Is there something about it, or is it just?
I think it's just altered level of consciousness.
Okay.
Do I have incontinence there?
Okay.
Yeah.
You said.
Oh, I just said. Go on. I felt like I had to say something about pelvis.
Oh, okay.
It's a paramedic in me. Someday I'm going to abandon it all. I hold on to these things like lung sounds for neurological patients, incontinence for respiratory. Like, if you didn't do it, I don't care. Scenario.
I was just wondering if there was something diagnostic
No,
about
it's
it.
just because I'm a tool by times, or probably more than some of the time. So 5 minutes to talk about. Thank you very much. I hope that cleared up abdominal and respiratory assessment a little bit. Even in neurological, you can think through. Neurological is kind of the one weird one. We had neurological tests first. That's why we kind of got into it first. But normally, I would like to change that in future. That we do the. It's gone now. But the one weird one. It's the one that has the most differences. If you saw that first assessment, or like, holy frig, this is all going to be really challenging. Neurological is the one freak amongst because it's a very different system. I want to talk about airway for 5 minutes. You can hop off your bed and relax for a second.
Thanks, Graham.
Thank you, Graham. Really appreciate it. Woohoo!
Can I get your autograph?
Good.
Can I throw this in?
You probably should.
Is my shirt?
It's like you should.
Thanks. Really appreciate it. Okay, so when we're into this new airway stuff, I wanted to mention a couple of things that often get forgotten. Do you mind grabbing me an intubation kit? You'd be really kind if you would. Out of that blue bag, we're using one's intubation kit.
You want to leave
So,
this running?
first of all, managing difficult bag valve mask. You walk up to somebody, you don't have a good chest rise and fall, and you decide you want to ventilate them. You put the bag valve mask on their face. You make a good EC technique. You pull the jaw up into the mask rather than pushing the mask down to the face. So it's pulling face into mask, not pushing mask onto face. And if that doesn't work, your first response should be to go to two-person bag valve mask. Okay? Because two-person bag valve mask is the fix-all. Okay? It works in just about every patient. So if I walk up, nice technique, EC technique, pull that jaw up, and then squeeze that bag, and their chest doesn't go up, then your first response is to go, squeezing that bag for me, and do this with it, right? If that doesn't get any chest rise and fall, I would presume foreign body airway obstruction, okay? Or airway obstruction, maybe if this was trauma or something. If this was I ran into a clothesline, this is going to be a surgical airway real quick. But that's how we troubleshoot it. Then we try to make it a one-medic job after this point. So then we'll add in, I gave you that acronym, MULE. I said make sure your mask seal is adequate, so reevaluate mask seal. Then open up the upper airway as best you can. NPAs, OPAs, maybe a King LT if they'll tolerate it. Lower airways, evaluate lung sounds to see maybe they're just really tight, right? So maybe we need to give some Ventolin, okay? And then equipment, make sure that you can create positive pressure ventilation. Pre-oxygenation for a patient, something that I did not know. You got your PEEP valve. Did you know that if you breathe through these disposable masks, something I didn't know until 2 weeks ago, this is a 2-valve system. Most of the ones in the hospital that are not disposable have 3 valves in them. So if you stick this on a patient's face, I've told you that you get 100% oxygen. I was lying because I didn't know. They can actually suck through here. It's useful information, isn't it? I didn't know you didn't know that either. So actually suck air. So they'll get like a non-rebreather kind of experience where they get high flow oxygen. But if you put a PEEP valve on this, that'll add your third valve as like the ones that are in the hospital that have 3 valves. So a PEEP valve with no pressure on it, it just allows them not to suck air. So if you're pre-oxygenating somebody before a procedure and they're breathing and you want to give them 100% oxygen as you're pre-oxygenating and you pull the bag valve mask in and we're going to set this on their face, we're thinking they were going to 100%, they weren't because Matthew didn't know. So I learned, you learned, we all learned.
So would you recommend
How did you find out?
putting the PEEP
I went to an AIM advanced course.
So would you recommend like everybody that you're going to bag?
They were suggesting, George Kovacs was suggesting that you should probably never use one of these without a PEEP valve on
put the
it,
PEEP
even if
valve
you
on
don't apply any pressure.
Just turn it down all the way.
Turn it down to 0.
And you
Just
can-
doesn't let them suck in.
So if you don't have a PEEP valve, we don't have PEEP valve, what else could you do? Just
Nothing.
Nothing?
Piece of tape?
Piece of tape.
Yeah, like, tape it?
I don't think I'd screw with it in that regards. I think when you open yourself to huge liability when you manufacture equipment to do something different than it's supposed to.
It's like we have PEEP valves, but should I be putting that on at the beginning of shift and just like screw
I
it right
see
on
no
there?
reason why your PEEP valve couldn't be on there all the time.
Yeah. Okay.
At 0. Okay?
Yep.
And it's actually, it's going to help. Pre-oxygenating is always going to be better with some PEEP. It's always going to increase. So how do we pre-oxygenate? Ways that, so that's difficult bag valve mask. Okay? Oxygenating before the procedure, some things that I want to reinforce when you're tubing people, is that we want to have pre-oxygenation, 8 vital capacity breaths, which hardly happens in our experience. Mostly this is 100% oxygen. If you were ventilating them, they were pretty well getting 100% oxygen because you're squeezing the air out of this bag and it goes in here. Okay? But it's when they suck, right, that they can get room air. Okay? So it's not when you squeeze the bag. It's just when they suck, okay, that they can get room air. But the ways that we can increase FiO2 or PaO2, pressure of oxygen in the blood, which affects, so if we're ventilating somebody an appropriate amount and they're not oxygenating to what we want, things that we can do, increase FiO2, you knew that, turn the oxygen tank up. The second thing is position, 30 degrees, remember hanging lungs, that will increase oxygenation. And the last thing is add PEEP onto it. Okay, 3 things, only things you can do to increase PaO2 is increase FiO2, body position, and pressure on top of that FiO2, or CPAP. Okay? So when you're pre-oxygenating a patient, if we get you SATs of 95% with bagging with 100%, I'm looking for you to sit that patient up, put a PEEP valve on, add 5 centimeters of pressure, and turn your oxygen up as high as you can turn it. During intubation, high flow nasal cannula. We talked about this, but I've noticed that it's been slipping a bit. So put the nasal cannula on while you're preparing. Okay? So put the nasal cannula on. When it's on, then you can, if you only have 1 cylinder, then you can switch it over and become that part of your thing. If you don't have high flow oxygen nasal cannula, use the one you have. Okay? I'd rather you have the high flow ones. They're a little bit bigger, but use the one you have. Turn it up to 15 liters, whatever it tolerate while you're intubating. So that means you just pull one port off, stick the other one on, then pull it off when you go back to the bag valve mask. Okay? So that should be done for every patient and every intubation. Managing difficult laryngoscopy. We've talked about it. Remember that airway sheet? You can flip to your airway sheet. Have that summary sheet. How do you manage difficult laryngoscopy? Burp.
Best looking. Best look, best position. Best lay. Burp.
That's my airway sheet.
Right for pressure.
So in the bottom, left-hand corner of this one, right here, bottom corner. So I've got best position, bougie, brutane, burp. So exaggerating sniffing position. So when you go in with your intubation, pre-intubation, and you get a grade, I tell you get a grade 1 view. Wow, we need to change the batteries in that. First of all, patient needs to, I'm a tall, lanky fellow, and this is a good height for me to intubate this patient. Okay? So first thing, work blade in, come across the right-hand side of the mouth. Remember the floppy tongue, if you practice going down the midline, it won't work in real humans. Okay? So you need to go to the right-hand side and then sweep over. So I insert the blade on the right-hand side until I can't see the tip of the blade, and I lift up a bit. Okay? Then I go in a little further, back to the right. So I'm continually, almost like my blade's coming diagonally across. This is my tongue. It kind of comes across like this. Okay, so I sweep in here, I'll sweep over like this, and then pull up to midline. Okay, so in, down the side, over, and sweep up. Okay, so continually sweeping. And usually it'll take 2, if not 3, little attempts to get down. So I'm first searching for epiglottis, then vallecula, to engage that hyoepiglottic ligament, then glottic opening. That's the order of what you're looking for. Looking for epiglottis, looking to get the tip of the blade in the vallecula, looking to see the air opening. So down, sweep in, sweep in, sweep in. This works. If you can do this well, obviously I tube a lot fewer patients. In the AIM course, could tube, and I do this all the time, but it's not going to be as good, but if you practice it actually like on a real patient, the head's going to be much heavier. These heads need to be like 15 or 20 pounds. So if we pick up somebody's head, it's got some weight to it. It's going to be much heavier, but if you do that, it will improve. Okay? Where I saw lots of folks that were in the course that hadn't been practicing do all sorts of terrible things with the laryngoscope. So you go in, work up. You notice that I automatically put my head, so hand on the back of the head. I often flip the head back to open the mouth, comb in, and lift up. I almost do this instinctively, okay, where I lift the back of the head up to get a better view. So I'm doing best blade position, exaggerated sniffing position, then bimanual. I don't have a lot of pressure. You notice I don't have a lot of pressure. If I needed to, most of you are going to want somebody else to pull on that blade, okay, bimanual, and then burp, which will involve somebody else. So your assistant may be pulling and having their hand here, and you're manipulating their hand, pushing their hand down and saying hold. Okay? When you pass the tube, anticipate that you're going to have to rotate the tube to get it passed. Okay? In a real patient, sometimes it happens in the mannequin, but your tube, the tip of it gets caught in the cartilage, and all you have to do is rotate the tube to the side to advance the tube. Okay? No forcing tubes. Need to rotate gentle. Forcing is bad. Reaming is bad. You teach your hands bad things here, and I guarantee you when you get dumb and excited in front of a patient, which I can do, I will do whatever my hands do here. Same thing with bag valve mask. If you're bag valve masking, I want you to do it perfectly, or I want you to stand there and say, I'm bag valve masking, we've been bag valve masking all day. I'm fine with either, but don't do the half-ass version. Don't teach your hands to do bad things, because you're gonna, if you hyperventilate here, you're going to hyperventilate there. I guarantee it. So either do it right or don't do it. I'm okay with either in a long day of scenarios, but I don't want you here kind of half-assed, pushing the mask on, squeezing every second, okay? Because that's what you'll do if you're not thoughtful about it. I want you to program your hands perfectly. So that's the first reaction. Second, so most of those interactions, of 90% of the intubations, I can get grade 1 view by doing, first, getting my blade into the right position. So find epiglottis, find vallecula, lift up into exaggerated sniffing position, find glottic opening, bimanual, and burp, and maybe bougie. But I should be able to get a grade 1 view on most patients with those 4 maneuvers. But I want you to have that programmed in your head that you do it instinctively. That's exactly what we're prescribed. Then we're going to go to an alternate blade, then an alternate device. We're going to have time to practice the alternate device. If those 3 attempts don't work, then we're going to sink a King LT into this patient or some supraglottic airway and try to ventilate through that. If that doesn't work, we're going to try bag valve mask. Your PCP partner is going to try bag valve masking while you get the surgical airway kit out, or prep the neck, or cut the throat while they're doing that. Okay? So it'll be very quick from failed. If your failed airway that goes through rescue airway, bag valve mask, surgical airway, very quick. Does that make sense? So if you don't get any chest rise and fall, if you try an extraglottic, you try 2-person bag valve mask, you can have one person try to continue ventilate to some degree if it's inadequately with a bag valve mask or an extraglottic while you're trying to do the surgical airway. But it needs to happen. Like, that is a shitty day, and it's going to happen in about 30 seconds if you actually do it right. And you're going to have to be definitive about it all. Some of you have misunderstandings about extraglottic. Remember, King LTs need to get shoved down to the hilt, inflated, and pulled back. So, because you need to pull that. If not, you can inflate that cuff and push that epiglottis over the glottic opening. That's why we shove down, inflate, and then pull the epiglottis up. Okay, you ventilate. King LT is probably anybody using a supraglottic airway other than King LT.
LMA for peds.
Use an LMA for peds. You'll have lots of practice putting LMAs in the OR. So I want you to have programmed really quickly that 4 maneuvers on the first look. Then you can do the exact same 4 maneuvers on a straight blade, right? Find the epiglottis. We're going to pick up the epiglottis with a straight blade. But same thing, brutane, burp, and exaggerated sniffing position, maybe bougie, and then on to alternate device. And if that doesn't work, we're going to just get out. Because these are sequential, fast. Okay, meant to be done with no ventilations in between. We've said no ventilations for the time being. There are rare circumstances that you may choose to ventilate in between. But let's just live in the normal right now and leave the exceptions out on the periphery for the time being.
Quick question. With lifting the head up,
Yeah.
can we not pad under the head with
You can. I
blankets
think
and
you'll
stuff
find it
on
much
the
easier.
auditorium?
Absolutely. I think you'll find it much easier with your non-dominant hand to actually play with the head.
Okay.
Rather than to put it in the position. You can try sniffing position, but you'll find most anesthesiologists or whatnot, they won't pad the head up. They might have a little donut, but often they'll grab the back of the head and lift it up
Okay.
to the ideal location.
Okay.
Because sometimes you go, oh, that's too far, that's good. Somebody else can hold that held for you. Some people have the patient close enough that they'll use their knee or their stomach to hold the head as they're lifting up. But it would be fine if you wanted your assistant to hold the head, because it is heavy.
My assistant.
But I don't want you to ream on an airway. So soft, gentle hands. If you're reaming hard, you need to slap each other's hands, literally or or not, and stop each other from doing it. Because if you do it here, you will do it in a real patient. In the OR, the anesthesiologist will be very cranky about it. So they want nice, gentle, controlled hands, very deliberate, no panicky. They want to see that you're to your much more developed brain, rather your panicked brain. Okay? And you might be panicked in this moment, but if your muscle memory remembers to do it right, that's what your default will be. Okay? You do here, and no forcing anything. If it doesn't go down the airway, who cares if it's a mannequin? Let's lubricate more. So we're going to start lab this afternoon at 1:15, because we're 12:15, and we'll see you folks then.